I saw a beekeeper about 2 months ago when I was thinking about this talk. And so I'm just going to present this as it happened. And things are messy in real life. So this is a really messy case. I haven't altered it all. The others were idealized cases. So 5 years ago, he had been kickboxing, had a few beers, took a taxi home. He said as he got out, he stood in a drain, turned his ankle, and he woke up the next morning with severe pain and swelling, and he couldn't walk. GP sent him for x-rays, which were reported as being normal, treated him with non-steroidals, but 3 months later he was still having trouble. And so because we got this thing in New Zealand called ACC, I don't know if you guys have heard about it, but he went to see an orthopedic surgeon privately on ACC. Naturally, the orthopedic surgeon got an MRI on ACC, and that showed structural damage. It showed no structural damage, just an effusion. So the surgeon gave him 3 intra-articular steroid injections over the next 3 years, all of which worked very well. And he also took diclofenac and prednisone episodically, and they worked very well, especially the prednisone. He was quite keen on the prednisone. In June this year, his hemoglobin dropped to 102, no doubt from his prednisone and diclofenac, and he developed an extremely painful left knee. So he went back to the orthopedic surgeon who got an MRI of the left knee. That again showed no structural damage, but a large effusion. So obviously the MRI had missed some structural damage, so he had an arthroscopy, but unfortunately no fluid was sent for analysis. So he was starting to become a bit of a bother to his doctors, so they referred him to rheumatology. Further history, he drinks a little bit. His father had gout, but only when he was older. And as things happen, his joints had been perfect for the previous 2 weeks. His hemoglobin had come back to 157. And looking back, uric acid levels had been done 5 times in the last 5 years. And those are the levels. Perfectly normal. So I examined him. He was a fit young man with absolutely no abnormalities in the joints, apart from slight restriction of movement of the right ankle. So what do I do?
Aspirate.
Aspirate what?
The ankle.
There's no fluid. It's completely normal ankle.
Tell him to give you a call when gets his next swollen joint.
Yes. I try to avoid patients giving me calls at any time of day or night, particularly because gout tends to start at 2 o'clock in the morning. Yes, of course. So that's what I did. And that is a look at his ankle from the medial-posterior aspect, and that is a small uric acid tophus in his ankle joint. So he's got gout.
Have you been on any treatment to reduce his uric acid level? Or that just is
No. It's just, yeah. He had traumatic problems on ACC until I unfortunately diagnosed his gout. Yeah. I mean, it's a problem because everybody wants it to be on ACC. The patient wants it to be on ACC. The doctor benefits from it being on ACC. So there's a blockage to diagnosing the gout.
Can trauma exacerbate gout?
Oh, hell yeah. Yeah. Hell yeah. That's the commonest thing.
So
Have a few beers, stumble on your way home, and you wake up with gout. So I'll just quickly show you this other chap that I just saw again about 4 weeks ago. He's got gout. He's had gout for a number of years. It affects his big toe, either foot, mostly the right, and he hasn't had gout for the last year. The cellulitis that he had in his foot and lower leg 4 months ago was not gout, it was cellulitis. But he's got real problems with his hands, and he doesn't know what's affecting his hands. It's definitely not gout. And his main problem now is that he can't flex his right third finger. So he comes to me, he's had very high uric acid levels, over 0.6, can't remember what they were. And he's got severe secondary osteoarthritis in the PIPs and MCPs with big nodules on the second and third MTPs, and he's clearly got gout, but he doesn't believe it. So if you look at his x-ray, he's got severe destruction of the second and third MTPs, particularly on the right. You can't really say that that's gout. I mean, the situation, the joints involved are typical of rheumatoid arthritis. This one, you'd say, well, it doesn't look typically rheumatoid either, but the destruction is so great you can't really tell. And then he's got damage at a number of PIPs as well. There is this large erosion on the left fifth metacarpal that looks gouty. I wouldn't put my life on it, but it certainly looks gouty. And then he's got cysts in the bones, but unfortunately you can get, in the carpus, you can get cysts in the bones in rheumatoid as well. Not usually quite as big as that, but still. So we do the Dualenergy CT. And this, okay, so he's got massive collections of uric acid. And as I said earlier, they're surrounded by low-grade granulomatous inflammation. And it's the granulomatous inflammation that actually causes the erosion of bone rather than just direct pressure of the tophus. Now, I show you this because it shows something interesting that's really only become apparent since people started doing Dualenergy CTs. If you look at his fourth flexor tendon here, it looks almost like pearls on a string. And you can see there's uric acid deposition on tendons all over the place. So clearly what we've been thinking of as a subcutaneous, largely joint inflammation, a lot of the time is actually a peritendinitis. And so this is his right hand, looking both sides. So this is lovely because you can just turn the hand around and look at it like that. So you only get two views. But if you look at his third finger here, he's got a lot of crystal deposition on the tendon with inflammation around it, and actually getting rid of that might indeed improve the movement of his finger, which is what I'm going to try and sell his urate lowering therapy with. I don't know if I'll succeed. He's pretty definite about things. So just a quick diagnosis summary. So ideally you show uric acid crystals in the synovial fluid or a tophus. You can use the clinical criteria diagnosis. X-rays or CT scans can show diagnostic changes or just typical changes. And then Dualenergy CT is magic. Remember that women can be atypical in their presentation, and these are the usual things to exclude. Management of gout comes in three sections, and I really want you to think about them as different things, and I want you to talk to your patients as though they're different things. So there's treatment of acute attacks, there's prophylaxis, and there's prevention. Intra-articular steroids are really, really useful, and I've said start treatment early, and early is less than 12 hours, but in my experience, intra-articular steroid injections work really well pretty much whenever you give them. Now, the typical osteoarthritic first MTP is a really difficult joint to get a needle into, but with gout, the joint is expanded with fluid, so injections actually aren't that difficult. And then we've got nonsteroidals, colchicine, prednisone, which are the usual things, and then the IL-1 blockers. Canakinumab is registered for treating acute gout if you've done 100 things before, and we expect anakinra will work as well, although it's not registered. I'm not going to say anything more about that. treating acute gout with biologics in New Zealand is a little way off. So I usually use naproxen and diclofenac. I guess you do as well. With naproxen, I suggest people take a gram as soon as they're aware that they're having an acute attack, and then 500 milligrams BD thereafter. Diclofenac, 150 stat, and then 75 BD. So I use the 500 milligram naproxen, which has a 12-hour duration of action, but the 75 slow-release diclofenac, because the 50 milligram diclofenacs are a bit short-acting. So the COX-2 inhibitors and ibuprofen are not that effective in gout. There are studies with both. The study with Celebrex showing that it was effective used 800 milligrams stat and 400 milligrams BD, which is a huge dose. I think if you're needing to use those sort of doses, just use something else. And obviously with the anti-inflammatories, you need to be aware of their comorbidities. So those of us who treat gout have known that prednisone works in gout for a very long time, but just in the last few years there have been 2 studies looking at 30 milligrams a day and 35 milligrams a day, showing that that's equivalent to indomethacin and full dose naproxen. So science backs up what we've been doing. You'll often see that a 5-day course is recommended. I don't think you can recommend a course. Some people, especially if they take it very early on, might only take a 1-day course or 2 days. Other people may need to go on for longer than 5 days. So I've put a little bit more information on the slide about colchicine, just because there are a few complications with it. Pretty much I don't use colchicine for treating acute attacks. The trend over some time now, 15 years, has been to use less and less, or lower and lower doses of colchicine, I should say. And there was a European study that showed that 1.8 milligrams in 24 hours was equivalent to 4.8. So there's no need to use the big doses that people did before. And the recommended treatment would be 1 milligram stat and half a milligram in an hour's time, as soon as possible. And it does work well if the patient takes it within 12 hours. How they're going to take it within 12 hours? By having the drug at home ready to take. And that's the only way to treat acute attacks, is to give the patient the drug so they have it when they need it. Colchicine takes a long time to leave the body, and it's 20% renally excreted, so in people with impaired renal function it's going to take even longer. People who are taking repeated acute courses need to be aware of it accumulating. Nausea, vomiting, diarrhea, they're in danger of becoming toxic. They should stop using it. A number of side effects. Be careful with the CYP3A4 inhibitors. Now, cyclosporin is not that common, but it's an extremely potent 3A4 inhibitor. Ketoconazole and clarithromycin are usually for relatively short courses, but watch out for verapamil, especially if you're using the colchicine for prophylaxis, and they're both ongoing treatments. And the same with statins. Colchicine will increase the risk of your patient getting muscle toxicity. So where I really like to use colchicine is in prophylaxis. And when I say prophylaxis, I'm meaning preventing acute attacks while I'm lowering uric acid levels. Okay. Some patients might use the word in other ways, where they're not lowering the uric acid level. So 1 colchicine a day is very effective in a number of people, and incredibly well tolerated at that dose. Or you could use low dose anti-inflammatories or a low dose of prednisone. I usually give 7.5 milligrams a day for 2 months and then drop it down to 5 milligrams. And when you're lowering uric acid, it depends on what the patient's uric acid load is, how long you're going to have to give that for. So in your guy who's had 3 or 4 attacks, 6 months will be fine. Somebody like the prison officer that I was showing you, 2 years is we're going to be lucky. The other criteria that I've used to stop prophylaxis is once the patient's been at target uric acid levels for 3 months and has not had any gout attacks, no matter how mild, I stop it then, and that works reasonably well. So, urate lowering therapy. This is the last little bit. There's been a move over the last 10-15 years to start urate lowering therapy a little bit earlier than we were before. And now recommendations are if patients getting 2 or more attacks a year. It used to be more than 3 a year. If they're less than 40 years of age and they've had a few attacks, they're certainly going to have repeat attacks for a long time. You might as well lower their uric acid. And if their uric acid is more than 0.48 and they've had an attack, then they're going to get a lot of trouble. And so you can do them a lot of good by lowering the uric acid. If they've got significant comorbidities, it might be best for them not to have acute attacks. So, as I said, our usual target is less than 0.36, but if they've got a lot of tophi, you want to get rid of their uric acid quicker, then go for less than 0.3. Try not to lower the uric acid below 0.2. It's not clear, but there is perhaps some association with neurodegenerative conditions, dementia, and measure uric acid monthly initially. I'll come back to that. So we always start low and go slow. We get less acute attacks that way. And we've got the 2 xanthine oxidase inhibitors and the 2 uricosurics. We can use them in combination. And then there's pegloticase, which is pegylated uricase, given as an infusion, 200 milligrams every 2 weeks, and that lowers your uric acid to 0 very quickly. In fact, I think the dose must be way too big. We should be using like 20 milligrams or something. This is obviously something that your patient will be in hospital receiving. So don't worry about it. I'm not going to say anything more about it. Allopurinol's our workhorse, and the vast majority of my patients with gout are taking allopurinol and enjoying. So with impaired renal function, I usually start with 50 milligrams, although you can use the 1.5 times EGFR to work out your starting dose. With severe renal impairment, so EGFR of 10 to 20, which is really severe, don't go above 200, and less than 10. I haven't got any patients with an EGFR of less than 10, don't go above 100. Apart from that, you're really starting at a low dose and steadily increasing and watching the uric acid. You're more concerned with the uric acid than with the creatinine in determining how far you go in increasing the allopurinol. I've suggested 600 milligrams here. The actual upper limit is 900 milligrams, but I think if you're getting up to 600 milligrams, you're probably going to want to refer that patient to somebody. I don't actually have anybody taking more than 600. I do something else when it gets to that level. Remembering, of course, the commonest reason for allopurinol to fail to control the uric acid is that the patient's not actually taking the medication or not taking it properly. Increasing monthly is fine. You can increase it quicker, but monthly is fine. The patient's had hyperuricemia for 30 years. You don't have to do everything in 2 weeks. And start the allopurinol when you see the patient. You'll see in the textbooks, wait 2 weeks after the acute attack has settled. Start it then. If you wait the 2 weeks, you're teaching the patient that allopurinol causes acute attacks. You don't want that. You don't want the patient, he's heard enough of that from his neighbors and relatives and stuff like that. And there's one small study of about 60 to 70 patients that compared starting during an acute attack and waiting the 2 weeks, and there's absolutely no difference. So start the allopurinol when you see the patient. And of course, when you see the patient, you've seen him because he's got gout. And never stop the allopurinol. However many attacks he may get, he never stops the allopurinol. So adverse drug reactions are a little bit more common with higher doses and with renal impairment, but that's not to say that you shouldn't use it at higher doses and with renal impairment. Maculopapular rash is quite common. Fortunately, scars are very uncommon. This is a European rate. So scars is severe cutaneous adverse reactions and the associated drug reactions with eosinophilia and systemic symptoms. These people are very unwell and can die and should be in ICU. And certainly the dress guys are often misdiagnosed as having septicemia. They're feverish, they got rash, internal organ dysfunction, very commonly liver dysfunction, and they actually need big doses of steroids rather than antibiotics. And then there are a few other side effects. Remember that azathioprine and mercaptopurine are metabolized by xanthine oxidase, and so if you're stopping the xanthine oxidase, you're going to get toxic. Febuxostat, trials show that it's more effective than allopurinol at 300 milligrams. Now, why did they stop the allopurinol at 300 milligrams? Well, you'll know as well as I do. Although it's metabolized in the liver, it's suggested that you don't give it with an EGFR of less than 30 mils per minute. The tablets are 80 and 120, so you can start at 80 and increase to 120. It's a special authority drug after allopurinol and probenecid. And as I said, the EGFR must be more than 30. Those are the common side effects. Scars and dress do occur, but are uncommon. There was a study where there was a numerically increased incidence of acute cardiovascular events that was not statistically significant, so there's still a bit of a question about that. Interestingly, hypothyroidism, it's not common, but it pops up every now and again in prolonged use, and again, you have to avoid with azathioprine and mercaptopurine. So probenecid is our very ancient uricosuric. With the uricosuric, you're putting lots of uric acid into the renal tubules. You need the patient to maintain good hydration, and you need a reasonable EGFR in order for it to work. I don't have any patients on 2 grams a day. I don't have any patients that have tolerated 2 grams a day. They get a lot of particularly upper GI symptoms, and of course it interferes with a number of commonly used drugs. Then benzbromarone is an incredibly effective uricosuric. The stated dose range is 50 to 200 milligrams. I've never had to use 200 milligrams. 100 milligrams seems to work fine in my patients. Again, you need very good hydration, and you need to do monthly LFTs for the first 6 months and then 3 monthly after that, because some years ago there were a number of cases of severe hepatic failure in Europe, and 1 or 2 patients died with it. So I'm not aware that any of my colleagues in New Zealand have seen problems with benzbromarone, and you need to avoid it in liver disease as well. It actually works down to an EGFR of 20 mils per minute, but the special authority guidelines say 30 mils per minute. And again, it's third choice after those. Remember that it potentiates warfarin. So there are a couple of key drugs that you need to remember with these urate lowering treatments. So there are two important things in treating hyperuricemia and gout, I think. The one is the target. Okay, and the target is keeping the uric acid at less than 0.36. And the other is the education of the patient. And they kind of go together. So what I would really like is for my patient to come in to the clinic room, say, Doc, I had a blood test a week ago, what's my uric acid? So I want them to be focused on the uric acid levels. And know that that is the important thing, not how often they get gout, which is kind of important as well. I want them to know what the different medications are for, and to know that we're not using allopurinol to treat their gout attacks. As I said before, a pill in the pocket for acute attacks is the only way to treat acute gout. And once people are adequately educated, you just have to trust that they will use it at the right time. Some of them don't. Yeah. I find frequent supervision essential in the typical gout patient, the 40 and 50-year-old guy who doesn't care too much about his health care. I can't see my patients 3 monthly, but I have a wonderful clinical nurse specialist, and so I get them to come back and see her 3 monthly. Focus on the uric acid levels, and I really stress the importance of these guys having their blood tests monthly to try and get home to them how important it is, and this is what we're treating. Obviously, you need to screen for associated comorbidities, and every speaker so far has spoken about the cardiovascular risks, so I'll just mention it, and then adjust the non-gout medications where appropriate. Thank you. I'll stop there.